I'm Glenn Campbell. I call myself a demographic philosopher. I'm looking at life and trying to predict the future through the lens of demography, or the study of human populations. I'm trying to view the world from the widest possible angle, as aliens would see us from space. So I'm interested in what large groups of people are doing, rather than individuals. In this episode, I want to return to a topic I've touched on earlier. It's the basic dilemma faced by modern medicine. Do you throw all of your resources into saving just a few people, or do you distribute your resources, trying to save as many people as possible? Serving as many people as possible involves some sort of rationing of medical care, because there's never enough medical resources to serve everyone. I brought this up in episode 37 earlier this month. This was an hour-long personal podcast about my cancer relapse and how my hospital was handling COVID-19. But there's actually some demographic philosophy buried in there somewhere, and I'd like to pull it out and talk about it a little bit. First, let me replay the relevant part of that episode from April 5th. It's about 6 minutes long. So there's a conflict in medicine that I've touched on previous podcasts and videos. And that's the difference between best practices medicine and triage medicine. Now, best practices medicine is when you pull out all the stops to save one patient. You want to give him the best of everything, and you try not to expose him to any kind of risk. And that's how medicine is practiced in the developed world. Whatever it is, whatever risk there is, we're going to mitigate it. Whatever the patient needs, we're going to give it to them. We're not going to compromise on anything. And this is actually backed up by our tort legal system in America, our system of lawsuits. If ever a doctor were to give a patient less than optimal care and something bad were to happen, the patient or their family is going to sue that doctor. That's how America works. So America really has no choice. American hospitals have no choice but to offer optimal care, best practices care to everyone. Now, the alternative to that would be triage medicine. Triage medicine is when you don't have the resources available to treat everyone. And this is true in about well over half the world. They don't have the medical systems to treat everyone. So they have to parcel out their resources in such a way as to save the maximum number of people. This is the sort of thing that would happen on a battlefield. Let's say you have a battlefield hospital, and you have 100 wounded soldiers that come in, and you've got beds for only a dozen of them. Who are you going to serve, and how are you going to serve them? That's an exercise in triage, in deciding how to parcel out your very inadequate resources. In the case of a wartime hospital, you're going to focus on the patients that you could do the most for. In other words, there's soldiers that come in that are so badly wounded that you can't do anything for them. They're probably going to die anyway, so you shunt them aside to begin with. And then there are soldiers who are so lightly wounded that they're going to survive no matter what you do for them, and they can get away for a while without medical treatment. So you put them aside, and what you focus on is that middle range of patients who can be most helped by the resources, limited resources that you have. And you don't try to give them perfect care. You give them just good enough care that you save them and can move on to the next patient. And you're playing a game of numbers here. Maybe you save them, maybe you don't. You're just trying to increase their odds. But when you're in triage situation, you have no choice. You have to make do with the resources you have. And that's rapidly approaching with the COVID-19 thing, that we're going to be in situations here where we don't have enough ventilators. We don't have enough facilities, doctors, everything to treat everybody. So somebody at some point has to make some triage decisions about who gets treated. But from the hospital standpoint, it doesn't happen here. It doesn't happen in Beth Israel, because Beth Israel, like every other hospital in the country, is focused on best practices and giving the patient everything that they need without any compromises. It's essentially unsustainable. In an epidemic like this, it's unsustainable, but there is this firewall between the hospital and the outside world. The outside world might have to deal with triage, but the hospital itself doesn't. The hospital is always, once you get into the hospital, you're guaranteed optimal care within the resources that they have. They might still not have enough ventilators, but they're going to do everything in their power to eliminate risks and give you everything you can to survive. Best practices is also essentially the philosophy behind all of these lockdowns. So when New York State or Massachusetts tells all of their citizens to go home and don't interact with anybody and keep a 10-foot distance or 6-foot distance between all people, and they're really practicing this sort of perfect medicine where they're trying to eliminate any kind of risk whatsoever. And I think the silliest example of that is closing the beaches in Massachusetts and elsewhere. The place you're least likely to catch a disease would be a beach, because there's all this huge distance between you and your fellow beachgoer that there's virtually no chance of catching it. But it falls under this blanket thing. This is basically lockdowns are basically a sledgehammer approach where we're going to eliminate every possible source of infection, no matter how unlikely. And like best practices elsewhere, the only problem is that it is frightfully expensive to do this. And the horrible expense here is that by locking down everything and shutting down the economy, you are destroying people's livelihoods. You are assuring a massive depression that's going to cause a lot more human misery than the virus itself. So the virus itself will be under control by the end of 2020. The Great Depression, the huge economic collapse, is going to go on for years and decades, and it's going to be made all the worse by the fact that these municipalities and states and countries impose these draconian lockdown rules instead of addressing the things that really matter. So now we're back at the end of April again, some 4 weeks later, and I've been in and out of the hospital in the course of my cancer treatment, and I've seen a lot of best practices medicine and virtually no triage medicine. When I experience the slightest anomaly, they order a whole slew of very expensive tests, which happened to me only a few days ago. I had this disruption in my vision where everything in my left visual field was kind of blotchy to the point where I couldn't work on my computer. So within a half hour of this happening, I told my nurse about it, and that set the wheels in motion to get all of these tests. There were 2 MRIs and a CAT scan and an EKG and consultations with 2 neurologists and an ophthalmologist. And they hooked me up to a heart rate monitor, which I'm still wearing, so they didn't miss anything. Without getting too deep into the details, there were 2 explanations for this phenomenon. There's the benign explanation and the slightly scary explanation that might affect my treatment. There's a high probability, I'd say 99%, that the benign explanation is true. It's only that 1% scary probability that triggered all the tests. And that, in a nutshell, is the problem with best practices. It's largely incapable of making compromises. Even a 1 in 1,000 chance of a bad thing happening is enough for the specialist to jump into action and order all these tests. And they're not going to rest until they've definitively ruled out this bad possibility. And that's one of the reasons healthcare costs are so high. It's not just a screwed up delivery system or all the well-known problems of American healthcare. There's also the problem that no responsible doctor can leave any stone unturned in assuring the health of their patient. If there's a 1 in 1,000 chance of something bad happening and it's within the power of the doctor to diagnose or treat it, they're going to be obligated to do that at huge cost to the system. Never mind that the patient is obese or a smoker, or the patient is 90 years old and will probably die of something else before the 1 in 1,000 risk ever happens. Doctors are obligated by the medical system, the legal system, and probably their Hippocratic oath to do everything they can for this patient, even if the risk is trivial compared to real-world concerns. Triage medicine, on the other hand, would have to take into account the real-world costs of diagnosis and treatment, and it wouldn't bother with relatively trivial risks. In my case, where there's a 99% chance that the thing is benign, the triage physician would say, okay, those are pretty good odds, so let's forget about those other unlikely possibilities. If doctors were allowed to make judgment calls like this, I think you would see a 50% drop in medical expenses because you're not keeping people in the hospital longer than necessary and you're not running all those superfluous tests. This cost savings means that more people ultimately will be served by the medical system and more people will probably be saved. There's only one place that I'm aware of in a modern hospital where triage medicine is actually employed. And that's when there are multiple competing diseases within the same patient. And doctors have to prioritize what they treat to save the patient's life. Let's say the patient has cancer, but he also has heart issues or vision issues or dental issues. But the patient is dying, so something has to be done quickly. And what we're going to do is we're going to focus on that one thing that's going to save the patient's life, and everything else gets pushed into the background. As soon as the patient's life is saved, however, and the time pressure is gone, then best practices kick in again, and we're going to run down every possible lead. This isn't an issue of socialized medicine versus the American capitalist model. This is a dilemma that's going to be faced by any medical system, even in Canada or the UK or any other country where medical care is supposedly free. The truth is, medical care is never really free. There's always somebody paying for it, and medical expenses are rising everywhere. They're helping to bankrupt countries like Canada and the UK because their costs are rising almost as much as ours are. As long as medicine keeps advancing, it naturally gets more expensive. If for no other reason that when you save someone's life, you're guaranteeing more medical expenses for them for all the extra years you're giving them. If the patient lives to be 90 because you saved him from a heart attack at age 60, you've guaranteed 30 more years of medical care that society has to somehow pay for. In Canada and the UK, I assume they still use the same best practices model that we use, which means if there's a 1% chance of something bad happening, they still have to run all the tests. No medical system in the developed world is really capable of making those really hard triage decisions about who lives and dies, where you're trying to prioritize patients to save as many as possible. In the modern world, survival is more a matter of whether or not you get into the hospital at all. If you get into the hospital, you're going to get optimal care. If you don't get into the hospital, you don't get treated at all, and you're going to die. There's really no middle ground. I'm not saying there's a solution. In an ideal world, you would ration medical care to save the most lives, without any delineation between rich and poor. But in the real world, it's more likely to be the rich with good health insurance who get treated. At the same time, a lot of people who have taken very poor care of themselves are also getting optimal care. If you never exercise, you smoke like a chimney and couldn't care less what you eat, the best practices system is going to treat you no differently than someone who's done everything right. In fact, it's the people with poor health habits who are soaking up a disproportionate amount of medical resources because the best practices system is not allowed to discriminate against them. No doctor is allowed to judge whether or not someone deserves to live. This means, ironically, that a 60-year-old death row inmate is going to receive exactly the same medical attention as a law-abiding college student with their whole life ahead of them. Now, a public hospital in a poor third world country is more likely to adopt the triage model. There's way too many patients and not enough resources, so someone has to make some hard choices about how those resources are used. If the choice is between saving one patient at huge cost or 10 patients at the same cost, the 10 patients are going to win and life-saving treatment will be denied to that one patient. As a regular customer of the best practices system, I really can't complain because I'm alive today because of all the resources that have been dumped into me. And I'm grateful for that, and I can't really see the system changing anytime soon. Doctors are trained to give every patient optimal care as though they were the only patient in the world. And this is fine as long as you live in a rich country with plenty of resources, but the system breaks down when the needs outstrip the resources. If that's the case, only a select few get optimal care and everyone else gets no treatment at all. So that's the end game of the best practices system. As healthcare gets more expensive, fewer and fewer people have access to it. It could happen to you because you don't have health insurance, or it could happen because wait times are so long that people die before they get into the hospital. There's no easy way out of this. Simply socializing medicine won't fix the problem because the issue will still be too many patients and not enough resources, no matter how it's paid for. The irony here is that the more medicine advances, the longer people live, and the greater their lifelong healthcare costs will be. In turn, this means that fewer and fewer people are going to get access to healthcare at all, and more of them are going to end up dying. I covered this in a video from June 2019 called The Medical Science Paradox: Why Longevity is Falling. My point there is that at some point, technical advances in medical science are going to stop saving total lives. A few chosen people may live longer and longer at ever greater expense, but overall longevity of the population may actually fall. Medicine may have already reached a steady state where it's not improving society anymore. So if you're interested in this topic, you might want to check out that video.